Welcome to the Journal of Graduate Medical Education Spotlight on Authors. I'm Dr. Halah Ibrahim, an Associate Editor at the Journal of Graduate Medical Education and Executive Director for Health and Wellness at NYU Abu Dhabi. The goal of this journal feature is to give our readers a bit of the backstory of some of the papers that we publish at the Journal of Graduate Medical Education. Today I'll be speaking with Dr. Frank Attenello, an assistant professor of neurosurgery at the University of Southern California. His paper, entitled Impact of the 2003 Resident Duty Hour Reform on Hospital-Acquired Conditions, a National Retrospective Analysis, is published in the April 2017 issue of the Journal of Graduate Medical Education.
So my name is Frank Attenello. I'm an assistant professor of neurosurgery here at the University of Southern California at the HACS School of Medicine. I work both with patients with brain tumors, but I've also had the opportunity to do a significant amount of research in patient outcomes.
Dr. Attenello, welcome, and thank you to you and your colleagues for this very interesting paper. I'd like to ask you a series of questions. My first question to you is, what was your initial interest in studying the relationship between duty hours and hospital-acquired conditions?
Well, I think there's two elements to that. The first is our variable of the limitation on what residents and doctors in training were allowed to work with the duty hours. And the association with the second of those aspects is the variable of outcome in the hospital-acquired conditions as a quality measure. And I think as far as the limitation on duty hours, I think that was widely applauded. And as a resident myself previously, I can say that there's a critical component of rest and personal time for the residents that they got that is good for well-being of both patients and doctors. But I think with that decrease in time in the hospital and with experiences comes a decrease in experience with sick patients and with procedures. And on top of that, when residents hit their duty hour limits, there's an increase in the number of handoffs that then have to occur of passing information, of patient information from doctor to doctor. So I think groups began to question whether these hypothetical positives and negatives really ended up benefiting the patient. Now, what they used in the studies to prove this, and results were mixed, but they used mortality and sometimes major morbidity. But if you think about it, individual patients, to get to the point of mortality, really need a lot to happen. So we might need a better quality measure as far as how patients are being treated. And the CMS came out with one for a variety of reasons. But with hospital-acquired conditions, you have events that should really never happen. They're costly. They really should be preventable. And I think the studies bear it out. As far as the last half decade, a reduction in 17% of these HACs show a reduction of $12 billion in cost savings, and much more importantly, 50,000 lives saved. So I think you have a good quality measure there.
My second question to you is, what are the implications of your findings for program directors?
I think the first thing to note about that is we have a good first step. We have a retrospective study with some interesting observations and correlations with our data analysis, but I think further analysis and study needs to be done. But if there is something to be believed, or some truth to this, with a decrease in resident hours associated at least with increase in complications, hospital-acquired conditions, and decrease in quality, well then program directors have two real jobs as far as educating the residents and improving and ensuring patient quality and safety. And educating residents, I don't think the response should necessarily be to increase hours, because residents need their rest, doctors need their rest, and that's not something to be debated necessarily. But I also think that there's less time, and I think that coordinators need to look at that and make sure that they're making the most of their time. Are their didactic events the best they can be? Are their resident rotations and the experiences they're going through as efficient and what they need to be going through? And if they are, that's great. There's a second aspect in ensuring patient safety. And on the back end, seeing if these hospital-acquired conditions or other quality measures are necessarily associated with residents. And if in evaluation it is, I mean, there may be opportunities for education, or there might be opportunities to institute protocols for those residents.
And finally, I'd like to ask you, what are the implications of your findings for the residents and trainees?
So I think the first thing and the first reaction should not be for trainees to think that we want them to work more hours, or this is some kind of critical analysis of the significant amount of time and effort they're putting into the residencies. I think as attending myself and with residents under me and having been a resident, there is a huge opportunity cost of family, of social events, and of other pursuits that is being done in order to put all this effort and time in. But I do think residents, as I said, need their rest, but they also need to make sure that they're embracing the time they do have, because there is less time to achieve what previous residents and now doctors are achieving when they go out there without a safety net. So embrace every opportunity, every procedure, every didactic session, every time you have an experience with an attending who has tons of experience. And on top of that, I think there needs to be really an embracing of what you are doing to patients. I think whether or not our study is absolutely correct, I think that resident actions have an effect on patient outcomes. And I think embracing something like the example of sign out, where you have this critical, really sacred time where you're passing off information from one doctor to an oncoming doctor that doesn't know that information to treat the same sick patient, that needs to be embraced. That needs to not be seen as a routine thing that maybe becomes so routine you're not paying attention, but really embraced and done well.
Thank you for joining us today. That concludes Spotlight on Authors for April 2017. I hope you read this very interesting paper.